Hi, good afternoon. We are Group 1 and we're going to be presenting about genetics and genomics today. I'm Leah Bagley.
And I'm Caitlin Register.
And I'm Jennifer Cason.
And we hope you enjoy our presentation. So what is genomics? The National Human Genome Research Institute defines that basically it's using genetic information to determine clinical care and health outcomes. So this is going to be impacting diagnosis, disease management, pharmacology, oncology, and many more. So this study has made groundbreaking strides in the world of healthcare. We are able to determine what causes diseases better, what is the better treatment, and how this can improve our healthcare of our patients. So now we can actually anticipate before the patient is born, what might be happening in them, and this can help save their lives earlier. This is just an overview of the history of genetics discovery. So as many of us know, in 1860 timeframe, Gregor Mendel conducted experiments that led him to the discovery of the idea of genetics. DNA was discovered in 1869, and then fast forward, DNA sequencing in 1975, and then in 1990, the Human Genome Project, which is really how we are utilizing the genetics in healthcare today. So genomics in nursing. The nurse is really one of the best resources for patients when it comes to genetic abnormalities. So the nurse is going to be spending the most time with these patients as well as the nurse practitioner. So getting a detailed personal and family history is important, which we will discuss a little bit later. Genetic diagnosis is incredibly challenging. So it's important for everyone in this field of healthcare to know what it means and how to address this with families. It's up to the providers to look at a bigger picture of what a genetic diagnosis might mean for the patient. Things are going to be different for them. Medications might be different. They might metabolize differently than others. So for example, a labor and delivery nurse or provider might notice the signs and symptoms of Down syndrome first. So it's important that they know what to look for and then base their care on that. Genetic testing is something that every baby in the United States goes through. They test for over 30 severe inherited and treatable genetic diseases. Also, prenatal, a lot of the times families will also be undergoing genetic testing, or if they have something in their family history already, they're going to be doing so. Pharmacogenetics are basically your body adjusting to medications differently. So certain medications call for this to make sure that your body is able to handle the medication, or just making the treatment more personalized to that patient. And this slide just tells us a little bit of the different mutations that might be present that indicate certain genetic issues like colon cancer or multiple sclerosis. So genetic impact on health. Essentially, the proteins that keep your body moving, if those are abnormal, your body is not going to work properly. So you could have small issues or you could have whole body issues. Sometimes this might be hereditary, so you might be born with this, or it could be acquired like through excessive exposure to UV rays or x-ray machines, that sort of thing. One explanation of early miscarriage is actually genetic abnormalities. So there are many issues where the individual might be a carrier, not actually have the disease. So that's something to be aware of too, especially for something like sickle cell, which is recessive. If the patient is recessive, you could see that in an offspring. So genes will not entirely determine your health. However, we do know environmental factors play a role, but it's definitely important to be aware of genetic issues early on.
Okay, now I'm going to discuss the genetics and genomics in practice. So as an NP, what does genetics mean to you? What are your responsibilities as a nurse practitioner for making sure your patient's taken care of? NPs must be prepared for a practice environment that includes understanding and, when possible, application of genetics and genomics. We need to become competent in collecting a thorough family medical history. This includes going back as far as 3 different generations to see what trends run in your family. Be proficient in identifying genetic red flags. We'll get to some of those red flags here in a few minutes. You want to organize family history and analyze. You can do this using a Pedigree, all kinds of different charts out there now with electronic health record systems to kind of organize and analyze different patterns in the families, and we'll have an example of a pedigree as well in a few minutes. Knowing your screening guidelines. For instance, we know at 50 years of age we start screening for colon cancer with a colonoscopy. But if a family member of yours has colon cancer, you may start screening early as 40 years or even 10 years prior to the age of onset for that family member. And then also as an NP, just knowing when to refer to a genetic counselor or specialist as needed. As far as conducting a family history, not only do you want to gather information from your patient, but you want to identify risks that are non-modifiable, modifiable, and help to teach your patient about the things that they can change, and then what things affect them that they're not able to change, and what things we need to tackle with a genetic counselor or with a specialist. These are the red flags you might want to look out for. Some of them are a patient who's diagnosed with something really early on, such as a patient who has a genetic marker for lung cancer being diagnosed as a young adult with lung cancer, and then multiple family members having the same diagnoses. This can be something as simple as hypertension, where the majority of cases we don't know what causes it. We do know that there's a genetic component and that it runs in families a lot of times. This is an example of a pedigree. For each of the shapes is a family member. It starts with you at the top and then works your way back down the family tree. There's different symbols that are used on this to specify who has a particular issue, who might be a carrier for it, and then that creates a pattern so we can determine who needs to be tested for things, who needs to be treated, and what our course of action is. And lastly, just the screening guidelines. We know that the U.S. Preventive Services Task Force has a lot of guidelines and standards for screening our patients for things, whether that's a colonoscopy for colon cancer, a mammogram for breast cancer, maybe a lipid panel for high cholesterol. These are things we need to know the standard guidelines for, and when there's a change. So again, going back to the colon cancer, knowing when you need to screen earlier on in the patient's life. In cases of increased risk for disease or disorder due to family history, the guidelines may change.
Okay, and I'm going to present on some of the questions that Group 7 asked us earlier in the semester through email. One of the questions they asked us was, how can an APRN best identify patients who might benefit from referral to genetic services / genetics counseling? One way is a thorough history can always lead to a better assessment and then to a more probable diagnosis. So like Jennifer stated earlier, getting a good family history, a subjective history, can lend to the NP knowing who would benefit from these services. The public expects nurse practitioners, NPs, to be informed about scientific advances and adjust practice as disease screening and management evolves with new research findings. So us as NPs, we have to be prepared as, patients come in wanting to be diagnosed and know how to refer and when to refer. Eliciting a thorough patient and family history of a minimum of 2 generations, more preferably 3 generations during the initial visit, can help identify patients who might benefit from genetic services. And examples of these include a patient's mother who has been diagnosed with breast cancer at the age of 35. That would lend us to screen this patient earlier by doing mammograms earlier, maybe at age 30 or even earlier than that. Another example is a patient's father who had stage 4 colon cancer, or a patient's aunt who was diagnosed with multiple sclerosis in their early 30s. Another question we had from Group 7 was, what are some ways I might help patients use the results of their genetic testing? There are a variety of ways we can help patients utilize the results of their genetic testing. For instance, if a patient is identified to have the BRCA gene, we can help them understand how this result can impact their future. We can aid them in secondary prevention by screening earlier. Examples of this include mammograms at an earlier age, prostate exams, and PSA levels drawn at an earlier age as well. And if patients do test positive for a colon cancer mutation gene, we can educate them on how to prevent by adhering to a fiber-rich diet. Results of genetic testing are not death sentences, but are helpful tools to educate patients on modifiable preventative measures they can take to aid in reducing their risk. Some implications of genomics for APRNs. How may the role of the APRN change as the field of genomics grows? As the field of genomics grows, patients' exposure and access to genetic tools and resources become more prevalent. Patients will seek out genetic testing on their own and question providers more. Patients will expect providers to be knowledgeable on the results of their testing, even if we did not order the testing. We will have to expand our knowledge base to accommodate patients' growing interest in their genetics to provide holistic care. What are some of the responsibilities of APRNs as genomics continues to grow? As genomics continues to evolve and expand, APRNs have a responsibility to expand our own knowledge of genomics. If a poor outcome occurs due to our failure as providers to refer for genetic counseling and subsequent treatment, then we are going to ultimately be held liable. How can we prevent, refer, and educate on the things that we do not understand? As APRNs, we will have to complete continuing education hours yearly. So what we can do is most of these hours will occur at conferences. We can be intentional by choosing classes that are presenting on genomics to help expand our knowledge base. Also, resources such as textbooks and websites, they can all be utilized in the patient care setting as well. And this is just describing how informatics and genomics are intertwined. I'm sure you've all seen on TV, on commercials, the Ancestry DNA kits and the 23andMe kits. They're all examples of easily accessible tools and kits the general public has to unlock possible gene mutations and risks based on family history through blood tests. And we're seeing more and more patients just interested and curious about their own history, that they're ordering these things and then getting results and bringing their results to their primary care provider and wanting to know what they need to do next. Patients are becoming more curious, like I said, about their own health and are accessing these tools on their own. As providers, we must be prepared to answer difficult questions related to genetics and make appropriate referrals and recommendations. Another thing, DNA databases are expanding, so that's another thing we have to be aware of. Are the expansion of these databases, are they groundbreaking and unleashing new correlations, becoming too muddled for dissemination, or are they causing more harm than good to the general public? These are questions yet to be answered. So in conclusion, the future of genomics looks more promising than ever. As APRNs, we must be competent in knowing what genomics is, our role of integrating genomics into practice, and the implications for current and future practice. We have to embrace patients' interest in engaging in new tools and resources. We must accept that genomics and informatics have made a large footprint in the clinical practice setting. We must accept that change in healthcare is inevitable and embrace the change by continuing to seek knowledge to provide the most comprehensive care to our patients. And these are just a few of our references and the last of our references. And that concludes our presentation. We hope y'all enjoyed.
Thanks.